all to Botswana COVID-19 webinar session number 14, titled What the Mirror Shows, Gender-Based Violence in the Face of COVID-19. This webinar is co-organized by Ministry of Health, Rutgers University of Botswana, and Botswana-Harvard partnership. Before I introduce today's presenters, let me take you through the webinar housekeeping rules. May you please mute your microphones and ask questions using the chat function. And a moderator will monitor your questions, and some of your questions will be answered through the presentation or through the chat box. The presentation is going to be recorded and made available after the session, both the full recording and the slides. And if you want to check on the previous presentations, you can check them on YouTube. I believe the link will be provided shortly, or you can just Google Botswana-Rutgers Partnership for Health, and then you can listen to all the previous 13 webinar sessions. And I might tell you that if you missed any of them, you have missed a lot. Find time to recheck them on YouTube. So if you want to join the emailing list, you can email armumakwa@yahoo.com. So now let me go ahead and introduce the first speaker. We are going to have two speakers today. The first one is Peggie Ramaphane. She's a women's rights activist, has been working as the Executive Director of Women Against Rape, Women Against Rape Trust in Maun since 2009. She holds a BSc with honors in pathobiology and chemistry, and she also has a diploma in accounting, a diploma in human resource management, and a higher certificate in theology. She has gained valuable and applicable competencies and skill in the gender landscape and the agenda of Botswana, SADC, and Africa through training and mentoring at national, regional, and international organizations. Peggie has initiated and fostered partnerships with international gender and human rights organizations to grow Women Against Rape as a resource center for gender-based violence, research and service center. So this organization is a key partner with National Gender Machinery in Botswana and the SADC Gender Unit, and has been a lead player in piloting national projects such as the phone-based gender-based violence referral system and the development of the national gender-based curriculum. Partnerships have been developed with Rutgers University in New Jersey on researching the effects of gender-based violence on women and their health-seeking behavior, and a number of papers have been published. So let me welcome you, Mayor Ramaphane, to take us through your presentation. We can wait. The stage is yours.
Thank you. Thank you very much, Member Tshisimogo. And welcome to this sharing of the mirror show, what the mirror shows, gender-based violence in the face of COVID. As Gontse has introduced, we have been working very much in the landscape of gender-based violence in Botswana for the past 25 years. So this year, Women Against Rape is celebrating 25 years working in this area. And we are a feminist organization promoting the rights of women and children. Women and children are the ones who are at the brunt of gender-based violence in Botswana and worldwide. Our vision is a Ngamiland and Botswana that is free of gender-based violence, and we believe very much that this can be achieved. Our strategic working pathways are that we do community education, we offer psychosocial support. We have one of the 2 safe houses in Botswana. You know, Botswana has got only 2 safe houses, one in Gaborone and the one that we own in in Maun, and these are run by NGOs. We also do economic empowerment for women, and we do research and advocacy. The organization is governed by a board of trustees and run by a management team with staff and volunteers. I would like to share with you, because most practitioners do not really appreciate how much research is done by government and civil society on gender-based violence. And for today's presentation, we want to call everyone who's participating and those who will be referring to this webinar to refer to the Botswana relationship study that was done in 2018, together with the Botswana Violence Against Children report of 2019. These reports are quite informative and relevant to our discussion on gender-based violence in Botswana. The partnerships that play in the gender-based violence landscape in Botswana are led by Gender Affairs Department in the Ministry of Nationality, Immigration and Gender Affairs. And this is our mother department that all civil society who work in the gender movement, the gender landscape, we report to Gender Affairs Department, and we move the mandate or the strategy of the country as led by the Gender Affairs Department. We work also in partnership with other government ministries and departments, especially in the justice, social service, education. We work with our dikgosi. It's very, very important that we work with our dikgosi in the villages, because gender-based violence affects everyone from the community up into cities, into the villages, whether you are educated or not. Gender-based violence affects you. So it's very important that we work with dikgosi. All the villages that we go to, we start at dikgosi as is custom in Botswana. We also work with development partners, private businesses, academics, and the media. Hence, this partnership with Rutgers University and also with the University of Botswana. Civil society organizations play a major role in preventing and responding to gender-based violence in Botswana. And Women Against Rape is just one of a network of organizations. I would want also to define what gender-based violence is, as defined by the United Nations, as all acts perpetrated against men, women, boys, and girls, underline men, women, boys, and girls, on the basis of their sex, which causes or could cause them physical, sexual, psychological, emotional, or economic harm, including the threats to take such action. So things like, I will kill you, I will murder you, I will beat you, that is the threat, that is gender-based violence. Gender-based violence is based on gender norms and unequal power relations. So when you are talking about gender norms, we are talking about the society. This is why we need the engagement and the participation of our dikgosi. We need the dikgosi, the village leadership, to be there so that when we interrogate, when we look at the gender norms, they are part of the process. GBV is largely rooted in individual and collective attitudes that condone violence in the family and within our communities. So as individuals and collectively as relatives, as community members, we contribute to how violence is treated in the communities, in the family, in our society. And gender-based violence affects mostly women and girls worldwide, not just in Botswana. And it is a human rights violation. Now, to get back to the research that has been done, gender-based violence in Botswana, the 2017 report shows us clearly that the prevalence of gender-based violence is more, or it affects mostly women. They experienced violence that was reported in 2017 by those who were interviewed. 37.1% of women experienced violence ever in their lifetime. And in the past 12 months, it was 28.1%. This is compared to the men's experience of violence, which was at 30.1%. So we can see that this violence, as from the definition, it affects both women and men, but proportionally more women are affected than men. And when you look at perpetration, who does the violence? In a lifetime, we see that men perpetration is quite high at 30.1%, and women's perpetration is 12.3%. So this says to us that more men are owning up to the violence at 30.1% compared to the 12%. And men's experience, or I mix these ones, men's experience is 20.8, while women's experience of violence is 37.1. So we see that 10%, in fact 17% more women experience violence than men, and 18% more men perpetrate violence than women in a lifetime. And this violence, when you look at the graph from the GBV study of 2017, it shows us that most of this GBV is intimate partner violence. It happens in the home, in the domestic, where people say they are together because of love. This is where the violence happens. Intimate partner violence and emotional violence is high, followed by physical violence and economic violence. Sexual violence coming at a low at 5.4% for women's experiences. And this shows clearly that sexual violence is not reported. It is not reported for various reasons that we know of, cultural, traditional, what people think, what people think about sexual violence. Both the victim and those who are listening, the responders or the first people to hear or to be reported to, whether it's the family, the service providers, the police, or health, our response affects whether the crime will be reported or not. So sexual violence, we can see, is not reported. The 2012 report on GBV, Botswana 2012 report, shows that only 1 in 9 cases of sexual violence are reported to the police. So there's a lot of underreporting when it comes to sexual violence, even in all other types of violence, but especially sexual violence. So we need, as a country, to look at our attitudes towards violence. Now, the study on children's violence, how children experience violence, also gives us another angle to look at where the violence starts. And this slide that I'm sharing with you is for service seeking for physical and sexual violence experienced in childhood amongst 18 to 24. These are the people that the young people that we expect them to be able to speak out for themselves, to be able to seek help where it's needed. But from this slide, from this research that happened in 2019, the Violence Against Children's report, it shows that when these children experience violence, only about 50% of them tell someone. We see that 48% of males, when they're sexually violated, they do tell someone. 68% of females, when they are sexually violated, they do tell someone. Physical violence, they're almost at 50% male, 50% female. But the shock is when you come to, do they actually get to seek services? Do they go for services? And do they receive services? And we find that the percentages go down. Only 3% of males who are violated, 18 to 24, actually seek services and receive services. The girls, the females, 21% of the 68% seek help. This is medical help, counseling, health, police. So only 21% seek help. But of that 21 that seek help, only 18% received the help. So it tells us that there is a deficiency, there is a disconnect between telling someone and going for services and actually receiving those services. For physical violence, it's also the same pattern. It's very low. It's at 10% of the 50% that go and report, tell someone, tell the parent, tell the parents, tell the relatives. Only 13, 11% actually seek services, and 8% receive services. And the reasons, as we can see, there is a lot of silence about violence. And this silence, this slide tells us that the silence on violence starts at an early age. We see that the girls and the boys, they're both saying we did not view this as a problem. So our Botswana, we don't see violence happening in the home, happening in the school, happening in our community as a problem. And this starts at an early age. So it's for all of us to now introspect and say, how do we get this violence problem out in the open, identify it, really identify it as a problem, and also to seek help. If these children, if these youngsters told someone and they were not taken for service provision and they did not receive the services, what has happened, particularly on sexual violence, especially looking at our HIV incidences, HIV prevalence in Botswana, they could have contracted the HIV. And from this, it links with the HIV rates when we look at the 18 to 24 cohort that the most affected. So the violence, the HIV, all is coming together. And they're saying they're embarrassed, especially for sexual violence, they're embarrassed. So this embarrassment goes back to the previous slide where only 5% of sexual violence is reported. So they do not report because they are embarrassed or they feel it's their fault. And this embarrassment is a societal measure. What are we saying as a society? So even, oh, that's okay, I've touched this. Now the approaches that we use at Women Against Rape is the use of the mirror. What we have, how we have titled our conversation is what the mirror shows, GBV in the face of COVID-19. So our approaches at Women Against Rape for prevention and response are based on mirroring to the community, what the community looks like, what the community approaches gender-based violence as. So we use the approach called SASA for preventing GBV and HIV. The SASA approach has been shown scientifically that it can be successful when used consistently, systematically within communities to prevent gender-based violence and HIV. And it is centered around community ownership process. The community has to own the process. The community, the host, the VDC, all the members of the community have to own the process, have to own and want to change. They need to identify what violence is, what gender-based violence looks like for their community, and want to change. Let us see the benefits of changing. We have to engage the whole community, the COSI, VDC, the influencers, the quiet, people with disability, men, boys, girls, everyone in the community. You need to have representation of all the genders. All the representatives of the community need to be there. The community leaders, the community support groups, everyone in the community, the church, the religious bodies, everyone, academia, media, everyone, they have to have representation. You must have the critical mass to be able to have a change in the community. We have to facilitate a process of change, and the process of change says it had to be phased in. It has to be a phased approach, understanding that change takes time, change is a process. So changing from a violent society to a non-violent society is going to take time. And we need commitment by the community, the whole community, owning the process and saying we want to go the extra mile. And during the process of change, there will be times when you go back, when we backslide, and the important thing is to come back on and carry on. And how do we do this? We facilitate repeated exposure to ideas. This is finding different ways, different methods of presenting the same ideas of wanting a safe, violence-free environment where women and girls are treated the same as boys and men, and are given the same power, they're given the same recognition in different ways. We have to show this to the community through drama, through poetry, through posters, through teaching. We have to find different ways. The media has to be involved. We have to work together repeatedly over the years to make sure that this change happens. And most importantly, it has to be human rights-based framework. We must know that gender-based violence violates the rights of the women and the girls. And we need to be driving a human rights-based approach all the time. Number two is we cannot do this alone. We have recognized this at Women Against Rape that we cannot make a change alone, or the civil society cannot make change alone. We need partners. We need to network with other organizations. We need to partner with government, with development partners, with faith-based organizations. All the key players, all the players have to come to the table, Because when you have a survivor, we have someone who has experienced violence, they will need to go to the hospital, they need to go to the police, they need to go to the courts. We need to bring everyone on board. If a student has been violated, education has to come in, guidance teachers have to come in. So we need everyone to come into the play and work with us. And finally, we advocate for access to justice. We have to stand up. We have to be the voice of the voiceless. We have to ensure that justice is accessed. We have to make sure that justice is meted to all the victims. And this, when we talk about justice, we are talking starting from the laws, from the programmatic implementation. How do the police address issues? How do the police do the investigations? The DPP, Department for Public Prosecutions, do they take the prosecutions all the way to assess the client? When we get to court, are these cases addressed on time, or the delays causing lack of access to justice? Justice delayed is justice denied. We have issues with cases of rape, defilement, domestic violence, taking time to be addressed through the courts. And we are always advocating for the survivors that they get access to the law. We want to see the actions that will change and make sure that everyone gets access to justice. So this is what we do at Women Against Rape. I'm going to hand over to Mr. James, who will be introduced to carry on and share the experiences of Women Against Rape and COVID-19. Thank you.
Thank you, Mayor Peggie, for the wonderful presentation. And I think we are learning a lot, because when you talked about, you covered quite a number of issues, and when you talked about the gender-based violence status in Botswana, and you are saying 31% of women experience violence in their lifetime, I think that's significant, because that's something that we know that there's violence out there, but I didn't think it was that significant. And when also you talked about, there is also an element of underreporting, and I think what we should encourage our people who go through violence, we should just encourage them that don't let fear or don't let embarrassment to stop you from reporting, because it really has to be addressed. And when you talked about the approaches in prevention, I think I like the fact that you're engaging the community, because without engaging the community, I don't think we can win, as most of these things actually happen in the community. And if you empower the community, they can actually also help us in sort of like reporting as well. Because I remember that sometimes when we have like students, the reporting can come from the school, and the school, they have to be empowered to do that. So I think for that, I commend you guys for doing that. So so now let me introduce our second speaker, Mr. James Baleseng, who is a social worker by profession, a University of Botswana graduate, who holds a Bachelor's of Social Work, and he has over 3 years experience working as a head of Psychosocial Support at Women Against Rape in Maun. Her main duties are to provide counseling and mediation services to survivors of abuse and gender-based violence, and to carry out an off-site workplace counseling and crisis intervention. James has been active in community work, providing education and awareness on gender-based violence, particularly challenging harmful social norms, underline those words, and inviting community leaders to question how power is used within their context. This is extended to the community members as a collective and individuals in their homes. So Mr. Baleseng is going to take us through a psychosocial supported war, the experiences during COVID-19 lockdown, which I think most of us can't wait to hear what the impact of COVID-19 on gender-based violence, and what does the mirror show on GBV. And so I think, Mr. Baleseng, the stage is yours. Thank you. Okay, Mr. Baleseng, go ahead.
Thank you. Hello, everyone. I will start by thanking you for this opportunity. This is what we do as a social worker here at Women Against Rape. I will take you through of the services that we do and that we were doing during the lockdown or during this COVID-19 era. As if you all remember from Mrs. Ramaphane's presentation, she mentioned that we have a shelter. So we are we have one of the two shelters in Botswana. So our shelter is called Chibuya Safe House. So during this COVID-19, our shelter was open. Was open to the survivors of violence because they needed a safe space. You will see this when I go through the presentation as to why we had to provide the shelter. So we also advocate for we advocated for alternative shelters because during this COVID-19, specifically during lockdown, we experienced many cases that led to our shelter being full, and therefore we saw the need to advocate for other alternative shelters by involving the community, the business people to lend us their hotels, because during lockdown during this COVID-19 era, most of the hotels they were not functioning. So we utilized that to assist the survivors of violence. We were also providing supportive counseling to the survivors of violence through the psychoeducation, also informing them, teaching them ways or the importance of reporting when they go through violence. And also we were doing mediation. Mediation came in when we had issues whereby people were living when domestic violence was happening within the home, and we had situations whereby a perpetrator would kick out another a victim of violence. So whereby they were left homeless. So that's where we came in, because now we can't take them into our shelter, because remember I said the shelters were full in that time. Therefore, mediation was also a way of trying to try and calm down, try to bring down those emotions within the homestead. We were also doing online counseling, because now we can't do our normal counseling, the face-to-face counseling. So we were doing online counseling that we're using our cell phones, our 24-hour helplines, and we also had a toll-free number that whoever whose life was threatened, or whoever who was being abused could call for help, and then we can see whether the client needed shelter or they needed us to do the mediation, of which we also did through the online, or if it needs to call the two parties to come and sit down with them. We did that, but considering the COVID-19 precautions. I will take you through now to the experiences that people, or the feelings that we observed as we were assisting our clients. Most people during this COVID-19, they were very conscious because of, they were very anxious. Sorry, they were very anxious, and this anxiousness is because of so many issues. So many issues surrounding COVID-19, so many issues surrounding GBV, because the main threat here was COVID-19. So COVID-19 brought in issues of economic stress. People lost their jobs, people were unsure of their future, and therefore they had these overwhelmed emotions, of which now they couldn't be able to unbottle these emotions. So they were unbottling them in so many ways now, of abusing the second party. So people had fears, others had lack of rest. For example, lack of rest, I mean, we as human beings, we need to sleep. We need to sleep at least 8 hours of rest. But during COVID-19, you didn't know, like I said, you didn't know whether you see the next day or not. You are sleeping the perpetrator in the same house, and you can't rest. You can't rest. Therefore, these are the emotions or the feelings surrounding COVID-19 that we observed as we were assisting our clients. As I continue, remember I said COVID-19 brought in, it was a test of character. So it was a test of character in so many people. And many people were confined in one space. They were stuck with an abuser. There was no place of refuge. They can't say, I'm running away from my abusive boyfriend or from my abusive husband to my family or my immediate family, because there were no movements. There were no movements allowed. Therefore, the safety of the survivor was compromised in that way. They felt helpless, and also there was no easy way to report GBV because of no movements, like I said, and because they can't. The other challenge is that they can't make those telephone calls to us as women against rape, because they were stuck or they were in that confined space with the abuser. And there's also a lack of freedom. When people are overwhelmed with emotions, the reason why there was so many numbers of abuse that we observed is because human beings are social animals. They unbottle their emotions in so many ways. They will go to watch a football match. They will go visit friends. They will go when they're angry. They will go air out their heated emotions in many ways. But because there was no chance to do that, then they unbottled in a negative way of like I mentioned, of beating children, beating wives, beating their family members. And also, the other things that we observed is that of poor coping strategy. As I said before, like people, COVID-19 is a test of character. As people lose fear, the fear to lose their jobs, they fail to find ways of how now to cope with the reality of me losing my job. So now they exhort in a negative way of trying to air out those overwhelmed emotions. And like I said, the other issue that the other image that we are seeing in our mirror is that of that shelters, like I said, shelters were full. Remember, our shelter is a 16 capacity. And we had to adhere to the COVID-19 regulations. We can't fill in clients up to the capacity that we normally do. So we had to put a little number of clients in our shelter so that we can adhere to the COVID-19 regulations. And also we experienced limited service from our stakeholders that we work with, because most of the services or most of the stakeholders, they were on lockdown. Therefore, we can't assist a client holistically as we do here at Women Against Rape. They have to, clients need so many services. GBV survivors need so many services. It's not only counseling. Others will need health service. Others will need the justice service, like Ramaphane mentioned. So during this lockdown, all those services they were closed. So it was only counseling, and the other services the clients couldn't get access to. With that, I think I've come to the end of my presentation. Thank you.
Thank you, Mr. Baleseng, for the presentation. And I think when you talked about the challenging in your bio, when I read about the when I saw challenging harmful social norms, I've said, I thought about that is something that is really, really important that we need to address in Botswana, because we have so many social norms that I remember them from a young age, even up to now. We still hear them being said, So I think that's something that you really, really have to focus on that in order to win this battle against GBV. And you also mentioned the statistics. Your shelters your shelters was full, because you said you had 16 capacity. So I was just wondering whether you had there was a time where you had to send some women away because you were too full that you couldn't take. And if that actually happened, what were some of the arrangements that you made? After this, I'll let you address some of the questions that were sent before the webinar.
Thank you, Gontse.
Yes.
Social norms. I'll start with the social norms that we challenge on our daily work at Women Against Rape. In Botswana, there are so many social norms, negative social norms that we feel need to be changed or challenged, such as issues of child marriage. Issues of child marriage, they are high in our country. So these are the social norms that we need to change, because her child has to be given the opportunity to grow up until they're in a right time to say they are ready for marriage, other than when they are just when they start to realize themselves they're already married. That's on its own. It's a violation of the child's rights, of which are human rights at the end of the day. The other norms are that of Botswana is mostly a patriarchy family. We are a patriarchy society, I mean to say. So, which means most of the powers are male dominated. So this also, that's where we come in to challenge that, we need to have that equity between the males and females, so that we don't give more power to men. Because at the end of the day, power with no wisdom leads to GBV, as we are seeing now. This power normally it's from the culture, is from religious perspectives. So that's a very social norm that we think needs to be challenged as well. The 16 capacity, our shelter, when it was full, remember in my presentation I mentioned that we advocated for alternative shelters, whereby we utilized those hotels that were not used because there was no tourism business. Therefore, we approached the district commissioners. Then we had to liaise, to work with them, to give them why we need to utilize those business facilities. And with the district commissioner, they helped us immensely. They helped us a lot to engage with the business owners. Then we had to open that, or to open those hotels, so that when our shelter was full, then we had option, I mean to say. Like in Gaborone, we opened, there were 5 more shelters that were opened for women and girls, and also 2 were for men. So you can see that we are not leaving the men outside. We are assisting human beings. Like I said, human rights is for men and women. Thank you.
Okay, thank you so much for that. And I think let me just applaud you for thinking about men as well, because I remember way back when I was working in one of the health facilities here in Botswana, there was a man actually who came and he was abused and he asked for shelter. And we didn't know where to send that man. And we ended up taking an option of sending that person to Sabrana. So you see, because he was like, there's nowhere to go. And imagine now you are sending somebody who is a victim of violence, domestic violence, to a mental institution, yet you know that the person was not mentally unwell. But I think it's a welcome development. So there were questions that were sent, but I think most of the questions were addressed during the presentation, because even I see that Peggie just sent the contact details, and the contact details in Francistown. So the only question that I think was not addressed during the presentation, that I'm not sure if it's your area, there is a question about what is happening in school programs to help young children. So I'm not sure if that's your scope of work, but it's a question that was asked. And the other question was, but I think this one also was addressed, why GBV during COVID-19? So you addressed that during your presentation. So I think that the one question that was not addressed is the school programs. So do you want to take that one, the school programs, or is something that you are not dealing with?
I will take it.
Okay, go ahead.
What we do, like we say, one of our services is advocacy. We have realized that there are guidance and counseling teachers in schools. So we approached them and shared with them our perspective and our opinions when it comes to GBV and COVID-19, that they need to, because children, they live in different environments. There being a family environment and a school. So they need to have to see help, to get access to help wherever they are. So they shouldn't be await service from Women Against Rape only. Therefore, we informed, we liaised with the guidance and counseling teachers and the government, social workers, the faith-based organizations, churches, to assist in that regard. And also there are other civil society organizations such as the BOCAPE, the Botswana Christian AIDS Intervention Program, and also Childline. Remember, we say this in a holistic approach. We need to share. It's all our fight. It shouldn't be the fight for women against rape alone. So any idea that we had, any view that we had, we had to liaise with the nearest office to assist.
All right, thank you for that. There's one question that I think was asked that I omitted. They're saying, how did it affect adolescents in particular? How did COVID-19 pandemic affected adolescents in particular in relation to GBV? Did you understand you get the question?
Let me hand it to Ramaphane.
Okay, all right.
Emma, what is the question? It's about adolescents. The
question is, how has the COVID-19 pandemic affected adolescents in particular?
Wow, that's a very profound question and very important. Adolescents, during the lockdown period and when the schools were closed, it meant that the adolescents, the teenagers, they were not going to school and they were confined in their villages. As Women Against Rape, we were part of the Ngadi health team that was going around the villages and the settlements, giving education, teaching people how to make face masks and wash their hands and all that. And we found that a lot of teenagers, they were in need of contraceptives, but there was no access to contraceptives. The condoms, they were not available. So we are expecting, and we have already had some reports of pregnancies that have happened during this time. So access to health, especially sexual reproductive health, was compromised during the period of lockdown and the period of the schools being closed. So this is something that we need research on it to find out how many pregnancies do we get, because the teenagers, the adolescents, they didn't have access to services. They didn't have access to contraceptives. They didn't have access to HIV testing, HIV prevention. So for Botswana, health implications that I think are going to be very high. In 9 months' time from the lockdown, we shall be seeing the results on the teenagers. And also the violence. I mean, the violence that could have happened or that has happened during lockdown and was not reported. These are the issues that we need research on to find out what was happening in the homes out there during the lockdown when the teenagers were not accessing services, not going to school. Thank you.
Okay, thank you, Ramaphane, for that response. And I think audience, she gave us some of the research topics that we must address. Research is important in Botswana. I encourage you to start doing research. Without research, no evidence, we can't do anything. So tomorrow you say a Minister of Health is not doing 1, 2, 3, but we need research for us to inform policies. So for now, let me take questions from the audience. Audience, anyone with burning questions that they would like to ask our presenters? Okay, Dr. Avalos, I see your hand is up. You can unmute yourself.
Thank you, and thank you for the wonderful presentations. I think this is so incredibly important, this topic, and I just have a couple of comments. One is that I'm really disappointed that only 25 people came to this webinar when over the weeks we've had 100 over 100. And I think this speaks to the fact that very often doctors aren't open and willing to talk about something that really they should be screening for on a regular basis. So I think I'm disappointed to that. And the other thing that I wanted to just say is that a lot of your presentation spoke to advocacy, but I think it's important that you say financial support specifically. You need to make an investment case on the consequences, the medical consequences of trauma and gender-based violence as people age. Huh? I mean, it's already been shown that trauma is a causative factor of cancer later on in life, right? All of these things that we just we don't look at the long-term consequences. And I think I was just, playing with numbers right now. I like numbers. And if we just took 1% of the HIV budget annually, you would have well over 5 million pula to deal with and to use for education, to use for more shelters. And we have to be using the almighty pula here when we're talking about advocacy, and to actually look and see how much money are you actually getting more, and shame people into helping, right? You have big donors even on this call right now. They should be thinking about, okay, how do we just take a percentage of our budgets and deal with this problem that is an epidemic? So I'm sorry, I get very passionate about it, but thank you.
Thank you, Dr. Avalos. And I think I'll give you Ramaphane to say something, but I think I agree with you as well, because I feel like doctors, I expected this for some reason, because like you are saying, doctors tend to shy away from things that actually they think is not non-medical. But you are right, this has to actually we should be screening for GBV. And I think it's something that we need to advocate for it, and we need to really integrate it into our primary care level or throughout, just screening for this. Because we see women who come to our clinics and we don't screen for this, and then at the end of the day, we are not doing much to help them. So I agree with you. Ramaphane, do you want to say something to what Dr. Avalos said?
Thank you very much. Dr. Avalos, thank you so much. From here, I have to like your page and follow you so that you can help me move this agenda forward. I'm equally disappointed because we have worked with the health ministry during the alcohol levy time to show them how alcohol is linked to gender-based violence. It's linked to depression. It's linked to the physical violence. There's like any violence that you see, the RTAs, road traffic accidents that you see are linked to gender-based violence. They are linked to medical costs. So it's very disappointing to see the health people not interested in gender-based violence, but they are the recipients. They are anything that is gender-based violence ends up in the hospital. It ends up at health. If a child is defiled and gets pregnant, they end up in your maternal hospital, your maternal death, your maternal complications. They come from defilement, which came from gender-based violence. If a woman is abused, you have depression, you have all sorts of mental health issues. They come from gender-based violence. And if the medical field is not screening for gender-based violence, we are treating just the symptoms and not going to the root causes. So it's very, very important that the medical fraternity looks at preventing gender-based violence, screening for gender-based violence so that it can be addressed socially before it becomes a medical problem. So thank you very much for identifying that. And also for the financial part, I'm very impressed with Dr. Avalos because gender-based violence costs so much, but us who are on the field, preventing, responding, highlighting, talking about it, doing advocacy work on it, very few people recognize that this is a national issue, that this is a global issue. We have governments signing on the United Nations conventions, signing on Africa Union protocols and agreements, signing on SADC agreements, national agendas done, but no implementation. There will be no budget to go with conventions that are signed, to go with laws that are put in place, policies. There is no budget. And most of the things will be left to civil society to do. And civil society, we have to struggle with the money. The people who work in civil society are actually volunteering their time. They are not paid. They are given allowances just to get on the combi to come to work, or to not even afford to pay rent in a proper house. If you see what civil society employees go through, especially on the gender landscape, HIV, yes, there's plenty of money, but on GBV, we are taking the crumbs that are not even good for our clients. The clients are not getting what they should be receiving because of poor funding. But people don't want the funders, those who have the money, those who can do a difference. They don't want to be identified with GBV. And it's the silence about gender-based violence. It's the silence because it affects everyone. And you'll find that those who don't want to put money, to put their hands into their pockets and give, they are perpetrators or they are survivors. And just to come out and say, I have experienced this, it's a problem. So we need people to come out, speak out, own up, because it affects everyone in every sphere, at every sector of the economy. We are all affected, and we really need the support because very soon hospitals will be full of traumatized individuals because of gender-based violence. So thank you very much for that comment.
Thank you. Thank you so much for that. It's well said. I'm not going to say anything because I completely agree with what you said. So let me take just one more question. If there's anyone from the audience who will want to ask a question before we close. Okay, so in the absence of question, I think we have come to the end of our webinar session, and I would like to thank our two presenters for such an enlightening presentation. And I think we really need to advocate for gender-based violence, inclusion in the budget, like you said, because what you said about these patients end up in the, they'll end up actually costing the Ministry of Health even more. So we can do much by preventing it. So I think it's something that we really need to take as an assignment and see how we can work together. So I'll say thank you for attending. The audience, thank you so much for attending today's webinar, and thank you our two presenters, Legamoso, So I think the next webinar session is going to be on next week, Thursday. Yeah, I think next week, Thursday, there's going to be another webinar. So the topic will be communicated with you in due course. Thank you so much.
Thank you and bye-bye.